Today we are going to discuss about heart failure. So these are the headings under which we are studying today's topic. That is, first is etiology, types of heart failure, stages, pathophysiology, and what is the pathology behind heart failure, and what are the complications of heart failure. See, heart failure is often called as congestive heart failure or congestive cardiac failure. Sometimes it would have been written as CCF. CHF and CCF both are same. It is a common clinical condition which is encountered in our practice. It is a progressive condition. Once it starts, it will progress to different stages. Okay, it has a poor prognosis. So what is the definition? Coming to the definition of heart failure, it is the condition in which heart cannot pump blood adequately to meet the metabolic demands of the peripheral tissue, or it can do so only at elevated filling pressures. Basically, the heart cannot pump blood to meet the metabolic demands of the peripheral tissue. What are the risk factors for heart failure? Chronic heart diseases like valvular diseases or hypertension, ischemic heart disease, example myocardial infarction, or acute hemodynamic stresses such as fluid overload, abrupt valvular dysfunction, or myocardial infarction. All these can precipitate sudden congestive heart failure. See, there are many conditions there are many diseases which can lead to final heart failure condition. So these are all the risk factors which can finally lead to heart failure. At first, before heart is failing or before heart failure happens, there are few compensatory mechanisms which the body will take so that there is no heart failure. What are those compensatory mechanisms? When the cardiac workload increases or cardiac function is compromised, physiologic mechanisms they come into action so that they can maintain the BP, blood pressure, and organ perfusion. These compensatory mechanisms are Frank-Starling mechanism. Second is activation of neurohumoral systems. Third is myocardial adaptations. What is this Frank-Starling mechanism? Increased filling volumes will dilate the heart, thereby increasing actin and myosin cross-bridge formation. This enhances contractility and stroke volume. See, to simplify it, take an example of a rubber band. If you stretch the rubber band more, it will give, when it comes back to its normal shape, it will come back with more force. The same happens with the heart. Whenever there is increased filling volume, there is more of stretching and there will be enhanced contractility and thereby increasing the stroke volume. What is the stroke volume? It is the amount of blood which the heart pumps during each ventricular contraction. Activation of neurohumoral system. First is release of norepinephrine. Second is activation of RAS system. RAS is renin, angiotensin, and aldosterone system. Third is release of atrial natriuretic peptide. What happens because of release of norepinephrine? Norepinephrine is released by adrenergic nerves of autonomic nervous system. This norepinephrine increases the heart rate. It increases myocardial contractility and increases vascular resistance. Because of increase in vascular resistance, there will be increased blood pressure. Second one is activation of renin angiotensin aldosterone system. This mechanism increases water and salt retention, because of which there is increase in circulatory volume. And second point is it increases vascular tone. So it helps in maintaining the blood pressure. Third mechanism is release of atrial natriuretic peptide. This will counterbalance the renin-angiotensin-aldosterone system. That is, it increases the RAS system, will increase the circulatory volume, or it causes salt and water retention, thereby increasing the fluid volume, correct? So here, when there is increase in that fluid, the atrial natriuretic peptide will come into action. It will cause diuresis, so that some amount of fluid, which is more, is excreted away from the body. Second thing is it causes vascular smooth muscle relaxation, which helps in decreasing the BP. These are counterbalancing mechanism for the RAS system. So remember that RAS and atrial natriuretic peptide, they act opposite to each other. Third important mechanism is myocardial adaptation. So here we are studying the compensatory mechanisms. Okay, we are studying about compensatory mechanism. In that third point is myocardial adaptation. In many pathologic states, heart failure is preceded by cardiac hypertrophy, okay, which is a compensatory response to increased mechanical workload. Whenever there is increased mechanical workload, this leads to cardiac hypertrophy at first. If at this time also the heart is not able to pump the blood, then finally it leads to heart failure. There is a term called as ventricular remodeling. See, this is the general term applied to collective molecular, cellular, and structural changes that occur in response to the injury or altered ventricular loading. Okay, see, whenever there is chances of increased mechanical workload to the heart will have many compensatory mechanisms. But if the compensatory mechanisms also fail, there will be heart failure. What is the pathophysiology and progression to heart failure? When there is sustained increase in the mechanical workload, either due to due to pressure overload or volume overload, or because of trophic signals mediated through beta adrenergic receptors, this will cause myocytes to increase in size. This we have already discussed. That is, increased mechanical workload will lead to cardiac hypertrophy. The same thing they are explaining. Okay. Hypertrophy leads to increased protein synthesis to form additional sarcomeres, as well as increasing the number of mitochondria, because the heart has to work more now. So because of this protein synthesis, additional sarcomeres, and increase in number of mitochondria, all these changes will cause hypertrophy. With these hypertrophic changes, the heart will be able to compensate that increased mechanical workload. But when the compensatory mechanisms also fail, okay, this leads to heart failure. There are two patterns of hypertrophy. One is pressure overload hypertrophy. Second is volume overload hypertrophy. So first one is pressure overload hypertrophy. It is due to hypertension or aortic stenosis are the examples for this pressure overload. In simple terms, I can tell, whenever there is outlet obstruction or when there is increased pressure against which the heart has to pump, for example in hypertension, this leads to pressure overload. In this, new sarcomeres are predominantly assembled in parallel to the long axis of cells. Okay, they are assembled in parallel. Pressure overload, parallel. Remember these two. Okay. expanding the cross-sectional area of myocytes in ventricles and causing a concentric increase in the wall thickness. And second type of hypertrophy is volume overload hypertrophy. For example, volume overload condition is due to valvular regurgitation. Okay, valvular regurgitation. In this, what happens? Say the ventricle will pump the blood, but since the valve is incompetent, again there will be regurgitation of the blood back to the ventricles. Fine. So what happens here in this? Sarcomeres are assembled in series. Remember, one thing I told is pressure overload hypertrophy, parallel arrangement. For volume overload, it is the sarcomeres are assembled in series within the pre-existing sarcomeres. This leads to ventricular dilatation. In dilatation due to volume overload or dilatation that accompanies failure of previously pressure overloaded heart, the thickness may be increased, normal, or less than normal. Any of these conditions will be seen because according to whether the previous heart was normal or it was already having pressure overload. Understood? Next is heart weight rather than wall thickness is the best measure of hypertrophy in dilated hearts. They are telling that you should look at heart weight rather than wall thickness. What are the conditions causing cardiac hypertrophy? Patients with systemic hypertension, ischemic heart disease, aortic stenosis, mitral regurgitation, dilated cardiomyopathy, they have heart weights double to triple the average. Aortic regurgitation and hypertrophic cardiomyopathy, they have 3 to 4 times greater the heart weight than the normal. Why hypertrophied heart is vulnerable to ischemia? What happens here? See, myocyte hypertrophy is not accompanied by proportional increase in capillary numbers because hypertrophied muscle cells or myocytes, they have to work more. They need more oxygen and more nutrients. How these are supplied? These are supplied by the capillaries or the blood. But when the myocyte hypertrophy is happening, there is no proportional increase in the capillary numbers. As a result, the supply of oxygen and nutrients to the hypertrophied heart is less than the normal heart. They need more and more blood compared to the normal heart. And there will be cardiac hypertrophy is associated with heightened metabolic demands due to increase in mass, heart rate, contractility, all of which increase cardiac oxygen consumption. Hypertrophy is typically accompanied by deposition of fibrous tissue, that is interstitial fibrosis, causing increased resistance to diastolic filling. Let me explain you this flow chart. Fine. See, these are the conditions which are causing either pressure overload or volume overload. Correct? See, hypertension leading to pressure overload. Valvular diseases, okay, it can lead to pressure overload and or volume overload, depends on what is the valvular disease. And third one is myocardial infarction. There will be regional dysfunction. All these conditions will increase the cardiac workload. There is increased wall stretch and leading to cell stretch. That is very simple. This we have already studied previously. Whenever there is increase in mechanical workload, the cell will undergo hypertrophy. Along with hypertrophy, there can be or there may not be dilation. Okay. This hypertrophy is characterized by increased in heart size and mass, increased protein synthesis, induction of immediate early genes, induction of fetal gene program, abnormal proteins, fibrosis, and inadequate vasculature. These are all the points which we have already discussed. So till the body can compensate with hypertrophy, it will go on compensating. Finally, at one point of time, when there will be decompensation, this will lead to cardiac dysfunction. Heart failure will occur. Either it can be systolic heart failure or diastolic heart failure, accompanied by arrhythmia, and neurohumoral stimulation will be happening. See, what are the types of heart failure? It can be left heart failure or it can be right heart failure. In this, left heart failure is divided into systolic failure and diastolic failure. Systolic failure is during the contraction. Okay. Diastolic failure is during the relaxation where the blood will come and fill in the ventricles. Fine. Systolic is during the ventricular contraction. Left-sided heart failure is most often caused by the following. And if they ask you which sided heart failure is more common, left-sided heart failure is more common. Okay. Left-sided heart failure is caused by, what are the conditions? What are the causes for left heart failure? Ischemic heart disease, hypertension, aortic and mitral valvular diseases, and primary myocardial diseases. The clinical and morphologic effects of the left-sided congestive heart failure. See, first we'll understand what happens. Left-sided heart failure. Left-sided heart is the one which pumps the oxygenated blood to all our body parts, to all the systemic circulation. Correct? Now, since the heart failure has happened, left-sided heart is not able to pump the blood. So what happens? Inadequate perfusion of the downstream tissues leading to organ dysfunction. This last point I am explaining. Okay. And now coming to this part, since the pump failure is happening, there will be stasis of blood in the left-sided chambers. Already stasis is happening in the chambers. So there will be back pressure, backing up of the blood in the pulmonary circulation or the lungs. This leads to passive congestion. So imagine that left-sided cardiac failure has happened. Then you can write all these 3 points. There is inadequate perfusion downstream, there is stasis of blood in the left-sided chambers, and there is passive congestion in the pulmonary circulation. How does the heart look in heart failure, left-sided heart failure, gross appearance? What is the gross appearance? The findings depend on the disease process. There will be many risk factors and diseases, heart diseases, which will lead to left heart failure. Those things can be seen. For example, there can be myocardial infarction. Myocardial infarct can be seen. And there can be valvular diseases which is leading to left-sided heart failure, stenotic valve or regurgitant valve. Or if it is primary myocardial pathology, intrinsic myocardial pathology, whatever is there, that pathology can be seen. How will be the gross appearance? The left ventricle is usually hypertrophied and often dilated also. Sometimes it will be massively enlarged. There are few exceptions for this. That is mitral valve stenosis. In mitral valve, okay, mitral valve stenosis, the left atrium will be enlarged because this left atrium is pumping against the pressure, okay, during the ventricular diastole. Or unusual restrictive cardiomyopathy. This also is usually having exception for this left ventricular hypertrophy. Understood? So, if you take sections from this left ventricle, which has undergone left heart failure. What are the microscopic findings you can see? You can see non-specific variable degrees of myocyte hypertrophy and also interstitial fibrosis. See, this is the section of the heart, gross examination, what you are seeing. This is the hypertrophy of the left ventricle. Left ventricle is, the wall of the left ventricle is thickened. It appears thickened. So this is the, in the picture B, this is the normal heart. So compare this normal heart with the hypertrophied heart. This is the hypertrophied heart, which is showing increased left ventricular wall thickness, correct? So compare this heart again. This is hypertrophy with dilatation. The wall thickness is not like hypertrophy. It is not much increased because this left ventricle has undergone dilation. Okay, understood? So when we take sections from this hypertrophied left ventricle, okay, what you see, this is the normal myocardial cells. And in the same power, you are seeing a hypertrophied heart muscle. Each muscle bundle is increased in size. And also compare the size of the nucleus, which has also enlarged. This is the interstitial cell. The interstitial cell is having same size. But the cells, cardiac myocytes, they are hypertrophied. They have been increased in size. When there is left ventricular diastolic dysfunction, diastole is where the blood fills in the left ventricle. So that is not happening. Or dilatation with mitral valve incompetence. See, when there is mitral valve incompetence, or I can say mitral regurgitation, whenever the ventricle, left ventricle undergoes systole or contraction, there will be backward flow of blood into the left atrium. Okay, in both the condition, there will be secondary dilation of the left atrium. This left atrial dilatation increases the risk of atrial fibrillation. Atrial fibrillation can happen, one thing. Second thing is stasis of blood, particularly in the atrial appendage, can lead to thrombus formation. Okay, now we are studying about left heart failure. Okay, left heart failure. We studied about the gross appearance of the heart. Now we are studying about the morphology of the lungs. See, when there is left heart failure, there is passive congestion which is occurring in the lung because there is a left heart failure. Left side of the heart is having pump failure. It is not able to pump the blood. So there will be stasis of blood in the pulmonary circulation. Okay? Pulmonary congestion and edema will produce heavy and wet lungs. We are talking about lungs now. Pulmonary changes can range from mild to most severe. There will be perivascular and interstitial edema, particularly in the interlobular septa. There will be progressive edematous widening of alveolar septa and accumulation of edema fluid in the alveolar spaces. We shall see all these with an example and an image. So this section is from the lung, okay, lung, which is having congestion, passive congestion. So these are the alveoli filled with edema fluid, few edema fluid. There may be few RBCs also along with this edema fluid. This alveolar septa, these are widened because of this edema, interstitial edema, and all the blood vessels are showing congestion. So this is the diagram you are supposed to draw. So this is how we see the section in our daily life, what we receive in the pathology lab. Okay, these are the alveoli. This is the alveoli. This is the alveoli here, which is filled with edematous eosinophilic pink material. This is the edematous fluid. There can be few RBCs also along with this edema fluid. What happens? Why these are important? Extravasated red cells and plasma proteins in the alveoli, they are phagocytosed by the macrophages. Okay, the red cells will have iron. Okay, now this macrophages will store all these iron as hemosiderin. These are called as hemosiderin laden macrophages or heart failure cells. Very, very important, heart failure cells. These are telltale signs of previous episodes of pulmonary edema, and also there was little bit of hemorrhage which was showing the RBCs, right? Okay, what are heart failure cells? These are hemosiderin laden macrophages which are seen in passive congestion of lung. Okay, in the passive congestion of lung, there will be RBCs and also edema fluid. These will be digested or phagocytosed by the macrophages, which will accumulate iron in the form of hemosiderin. These hemosiderin-laden macrophages are called as heart failure cells. There can be pleural effusion of serous type from the elevated pleural capillary and lymphatic pressure, and the resultant transudation of the fluid into the pleural cavity will lead to pleural effusion. It's because of the increase in the pressure. So it will be a transudate usually. Okay, till now what I was explaining you, this is the image. This is the image you are supposed to write for congestion of lung. Congestion of lung. What happens? These are the heart failure cells. These are hemosiderin laden. These dots what you are seeing. These are the hemosiderin laden macrophages which have engulfed the RBCs. So from these RBCs, they are getting the hemosiderin. Okay, this is intraalveolar RBCs. These are heart failure cells. Okay, in this diagram, okay, these are the alveoli. This is the outline of the alveoli. These are the heart failure cells which you are seeing. So when the patient is having left-sided heart failure, what are the clinical features he presents with? Early left-sided heart failure symptoms are related to pulmonary congestion and pulmonary edema. What happens? There is pulmonary edema, cough and breathlessness. But when the heart failure is very mild, the cough and breathlessness, they occurs only with exertion. When they try to do more work only, they'll have all these symptoms. But as the congestive heart failure progresses, there will be worsening of the edema, and the breathlessness will become more, leading to orthopnea. Orthopnea is dyspnea when the patient is in supine condition. When he wakes up, if he is in sitting position or standing position, he'll be all right. But he'll not be able to sleep in supine position. As soon as he sleeps, there will be dyspnea or breathlessness. One more thing is PND. This PND, how do you define this PND? Paroxysmal nocturnal dyspnea. It is a dyspnea, okay, occurring at night. It is very severe. It induces a feeling of suffocation. And all these will be there. If again CHF progresses to worse state, then dyspnea will occur at rest. Even if the patient is at rest, dyspnea occurs. When you auscultate such a patient with left-sided heart failure, in the respiratory system, you hear fine rails at the lung bases. Fine rails are seen. In CVS, there will be tachycardia and S3, S4 heart sounds may be seen. When you do imaging, echo, you can see cardiomegaly, that is enlarged heart. Now, if the heart failure is associated with progressive ventricular dilation, what happens then? The papillary muscles are displayed outwards and there will be mitral regurgitation. This leads to chronic dilation of the left atrium leading to atrial fibrillation. Atrial fibrillation will reduce the atrial contraction and thereby its contribution to the ventricular filling. So the atria is not able to contract properly because of this atrial fibrillation. The volume of blood which is entering from atria into the ventricle is reduced. So the ventricular filling itself is reduced. Obviously, the ventricular stroke volume will be reduced. In moderate congestive heart failure with a reduced ejection fraction, when the ejection fraction is less, there will be diminished renal perfusion. This leads to activation of renin, angiotensin, aldosterone RAS system, which leads to salt and water retention. There will be expansion of interstitial and intravascular fluid volumes, which will exacerbate the ongoing pulmonary edema. It exacerbates the pulmonary edema. Again, the patient will end up in breathlessness. If the hypoperfusion of the kidney becomes very severe, there is impaired excretion of nitrogenous products, leading to azotemia. In far advanced congestive heart failure, there will be cerebral hypoperfusion, leading to hypoxic encephalopathy with irritability, loss of attention span, and restlessness. It progressed to stupor and coma with ischemic cerebral injury. This is what is happening in the central nervous system. Left-sided heart failure can be divided into systolic failure, diastolic failure. Systolic failure is pump failure. The left-sided heart is not able to pump the blood. It can be caused by many of the disorders that will damage or derange the contractile function of the left ventricle. Diastolic failure is the left ventricle has become abnormally stiff. It is not able to relax properly so that blood can enter the left ventricle. Although in diastolic failure, the cardiac function is relatively preserved at rest. At rest, the patient is not having any of the problems. But the heart is unable to increase the cardiac output in response to any of the increased metabolic demands. For example, during exercise, there will be more need of blood in the periphery. Okay? Exercising muscles should get more oxygen and nutrients. But what happens? The heart is not able to, left ventricle is not able to relax. Okay, it is abnormally stiff. So the amount of blood entering will be constant. Even if there is increased demand, the heart is not able to supply. See, because the left ventricle cannot expand normally, any increase in filling pressure is immediately transferred back into the pulmonary circulation and it will produce pulmonary edema. Why there is diastolic failure? What are the causes for that? Hypertension, diabetes mellitus, bilateral renal artery stenosis. These are the causes for diastolic failure. Reduced left ventricular relaxation stems from myocardial fibrosis, which is seen in cardiomyopathy and ischemic heart disease. Also, it can be because of infiltrative disorders associated with the restrictive cardiomyopathies, example, amyloidosis. Diastolic failure, it may appear in the older patients without any predisposing factors. This is because of the normal stiffening of heart with the age. One more cause for this diastolic failure is constrictive pericarditis. Okay, it will limit the entire myocardial relaxation and it will mimic primary diastolic dysfunction. It is basically a mechanical restriction, I can say, this constrictive pericarditis. See, till now we were discussing about left heart failure. Now we will study about right-sided heart failure, right heart failure or right-sided heart failure. What happens in this right-sided heart failure? This right heart failure is most commonly caused by left-sided heart failure because any increase in pressure in pulmonary circulation from the left-sided heart failure, it will burden the right side of the heart because the right side of the heart, it receives blood from the entire body. Okay, venous circulation, venous drainage happens into the right-sided heart. From the right heart, it is pumped into pulmonary circulation or lungs for the oxygenation. That all the deoxygenated blood, venous blood will flow into the right-sided heart. From there, right ventricle will pump it into the pulmonary circulation. Remember this. So whichever will increase the pressure in the pulmonary circulation will lead to increased pumping pressure to the right-sided heart. This right-sided heart has to pump against that pressure. So at one point of time, it causes right-sided heart failure. Isolated right-sided heart failure is infrequent, but typically it occurs in patients with lung disorders. Hence, it is called as cor pulmonale. This term is very, very important, cor pulmonale. What is cor pulmonale? It is right-sided heart failure. Right-sided heart failure occurring due to disorders affecting the lungs. Okay, disorders affecting the lungs. Apart from this lung diseases, parenchymal lung diseases, cor pulmonale can also arise secondary to disorders that affect pulmonary vasculature. Example, primary pulmonary hypertension. Here also, the pressure against which the right heart has to pump will be increased, and thromboembolism, recurrent pulmonary thromboembolism, where the heart has to pump against that thrombus, or any conditions that cause pulmonary vasoconstriction, obstructive sleep apnea, altitude sickness. All these are the causes why right-sided heart failure is occurring. The most common feature of these disorders is pulmonary hypertension. Okay, because of this pulmonary hypertension, there will be right-sided hypertrophy and dilation of the right-sided heart. In extreme cases, there will be leftward bulging of the interventricular septum and can cause left ventricular dysfunction. The major morphologic and clinical effects of primary right-sided heart failure, okay, will differ from those of left-sided heart failure. What happens in the right-sided heart failure is more of systemic and portal venous system is mostly congested. Okay. In left-sided heart failure, pulmonary edema, pulmonary circulation was engorged. Okay, there was congestion of pulmonary circulation. In right-sided heart failure, systemic and portal venous system is engorged or congested. In right-sided heart failure, what will you see in the heart? Gross appearance, how the heart will appear. See, basically cardiac morphology varies with the cause, okay? For example, there can be valvular defects like tricuspid and pulmonary valve abnormalities or endocardial fibrosis can be there. But main thing is isolated right heart failure is most often caused by lung disease. Most cases exhibit only hypertrophy and dilatation of the right atrium and ventricle. This is what you're going to see. Okay, in right-sided heart failure, what is happening for liver and portal system? Okay, congestion of hepatic and portal vessels are seen. Okay, because of which there will be changes seen in the liver, spleen, and gastrointestinal tract. Liver is usually increased in size and weight, leading to congestive hepatomegaly, which is caused by passive congestion. Greatest around the central veins. The gross appearance of the liver is called as nutmeg liver. Nutmeg liver. So why it is called as nutmeg liver? This is reflected as congested red and brown pericentral zones with relatively normal colored tan periportal regions. See, they have already told the central veins, the area around the central vein is more affected. Okay. So the pericentral zones, they are congested red to brown, and normal appearing tan color is seen in periportal regions. So this is the reason why there is nutmeg liver appearance. See, in some instances, especially when the left-sided heart failure with hypoperfusion is also present, severe centrilobular hypoxia produces centrilobular necrosis. That is, around the central vein, there will be necrosis of the hepatocytes. We'll show you the picture. For time being, understand this. With long-standing severe right-sided heart failure, the central areas become fibrotic. Okay, eventually they culminate in, they'll end up in cardiac cirrhosis. Portal venous hypertension also causes enlargement of the spleen with platelet sequestration leading to congestive splenomegaly, and also can also contribute to chronic congestion and edema of the bowel wall. Because of this edema of the bowel wall, there will be defective nutrients or drug absorption. So this is the appearance of nutmeg liver, which is seen in congestion of liver. It shows mottled appearance, alternative pattern of dark congestion with pale fatty chain. So if you take a section from this nutmeg liver, what do you see? This is the central vein. Surrounding it, there will be central hemorrhagic necrosis. So this is the portal triad. The cells which are close to this will show a fatty change. The cells which are surrounding this central vein, they show necrosis. So this is the same image. Yes, central areas are red and slightly depressed compared with the surrounding tan. Tan color area is the one which is viable parenchyma, alternating with this central areas which are appearing red. So this appearance is called as nutmeg liver pattern. And this is the centrilobular necrosis. This is the centrilobular necrosis with the degenerating hepatocytes and hemorrhage. Systemic venous congestion leads to fluid accumulation in all these areas, pleural, pericardial, peritoneal spaces. All these things will happen. Large pleural effusion can lead to atelectasis, and very large ascites, gross ascites, will limit diaphragmatic movement, causing dyspnea. It is mainly mechanical based. Subcutaneous tissues will have edema of the peripheral and dependent portions of the body, especially the foot ankle, which is called as pedal edema, and there can be pretibial edema. These are hallmark of right-sided heart failure. In bedridden patients, it will be seen in sacral region. Okay, sacral region. If there is generalized massive edema, it is called as anasarca. Kidney, brain are also affected in the right-sided heart failure. Renal congestion is more marked with right-sided heart failure than left-sided heart failure. It causes fluid retention, peripheral edema, and there can be azotemia also. In the CNS, what are the changes? Okay, deficits of mental function, similar to those seen in left-sided heart failure, with poor systemic circulation. With poor systemic perfusion. in many cases of chronic cardiac decompensation, okay, the patient can have biventricular failure. Both the right-sided heart and left-sided heart can be having congestive cardiac failure. There is a laboratory test which we are going to do in case of congestive heart failure. It is called as brain natriuretic peptide or BNP. Serum levels of BNP, it has become a popular tool to quantitatively assess the extent of CHF. It is released by the ventricular cardiomyocytes during increased wall stress. If BNP is very low, it is a negative predictive value for congestive heart failure. Echocardiography also we can do. Echo is an extremely valuable tool in the following patients with CHF, providing a measure of ejection fraction, wall motion, valvular function, and it will also identify if there is any mural thrombosis. So first thing is BNP should be done and the patient should be subjected for echocardiography. How do you treat CHF? Basically, we have to treat the underlying cause. If there is any valvular defect, we have to treat that, and we should help the patient for the corrective measures. Only supportive measures can be done, but if you have to treat the underlying cause, then only there will be permanent solution for this CHF. What are the supportive measures which can be done? Salt restriction and agents which will reduce volume overload. For example, diuretics, they will decrease the circulating fluid volume. Second thing what you can do is increase the myocardial contractility by giving ionotropes or reduce afterload via ACE inhibitors. ACE inhibitors also limit myocyte hypertrophy and cardiac remodeling. We can also try resynchronization therapy and ventricular assist device. Thank you.